Good morning, my name is Tariq Gadar, and today we're going to talk about the basics of nucleotide excision repair and xeroderma pigmentosum. So overall, there's two general pathways used, to repair double-strand breaks, DNA double-strand breaks. We're not going to talk about mismatch repair. I just want to introduce it as a concept because one of the upcoming videos will talk about it. And I sort of want to emphasize these two genes here, MSH2, MSH6, MLH, because there will be a discussion about those genes. Moving over to this side, what we're concerned with today is nucleotide excision repair. Don't worry about what's in the middle right now. I want to emphasize that we're going to look at the role of the xeroderma pigmentosum proteins and some of the transcription-coupled nucleotide excision repair proteins, how they interact with transcription factor 2H, how that unwinds the DNA, and how that allows endonuclease activity to repair the DNA. Nucleotide excision repair is essential for the repair of UV light damage, and the main defects of nucleotide excision repair, the first manifestation will be severe burning the first time a newborn goes into the sunlight. If a newborn goes into the sunlight for like 5 minutes, 5 minutes of sunlight, and has these severe blisters and burns, that's very indicative of an underlying nucleotide excision repair mutation, or at least the possibility of it. And nucleotide excision repair either occurs during transcription, and that's mediated by CSA and CSB, or outside of transcription, which is mediated through the xeroderma pigmentosum genes. All right, and the xeroderma pigmentosum genes include XPA through XPG. But the ones that will initiate it outside of transcription, the main one is XPC. I don't believe it's likely that you're tested on that. What I do want to emphasize is that xeroderma pigmentosum is associated with defects in nucleotide excision repair. And there's a second disease state called Cockayne syndrome that tends to be more involved with these mutations. Cockayne syndrome A, Cockayne syndrome B, xeropigmentosa A, xeropigmentosa G. In case you're ever confused or you think you're going to get them mixed up, just remember the CS overlaps and XP for xeroderma pigmentosum, CS for Cockayne syndrome, XP for xeroderma pigmentosum. During Cockayne syndrome, is more involved with the proteins that occur during transcription. Xeroderma pigmentosum is more a concern with global excision repair, although there's some overlap between the two disease states, which you would expect because at the end of the day, they're working through the same pathway. But all I want you to know right now is that xeroderma pigmentosum is a defect of nucleotide excision repair, and there's a number of genes that can be mutated. So generally speaking, we're going to go more into detail of this later, but like I said, there's two arms. There's either transcription-coupled repair or global excision repair. In transcription-coupled repair, you have this thymidine dimer or whatever, lesion in the DNA, and the RNA polymerase is going to be reading, and then it gets stuck. The moment it gets stuck, that is a signal that there is damage. All right, when RNA polymerase gets stuck on something, because you want to think of it as like sort of like Pac-Man making its way in a line, like you're eating the dots in one of those Pac-Man games, you're making your way in a line, then all of a sudden you start bumping into something and you can't go forward anymore. And that stalling of the RNA polymerase, because its structure is no longer compatible with the DNA, it gets stuck, that indicates that there's damage, because if there wasn't damage, it would be a smooth ride. So that recruits XPG, which is an endonuclease, and CSB. All right, and you don't need to memorize that. Just know that in nucleotide excision repair, broadly speaking, the transcription-coupled repair arm is initiated when RNA polymerase stalls during transcription, and that leads to recognition of damage. That leads to the unwinding of the double strand. So you get two single strands instead of one double strand. You get unwinding through transcription factor 2H, which has helicase activity. If you're ever confused about that, just H, helicase. It goes together. All right, so the DNA helix is unwound, and XPG and XPF perform their endonuclease activity, and this lesion is excised. It's removed, in other words. So it's almost as if you have a piece of skin, you make a cut here, you make a cut there, or think of it as like a string, actually, probably a better idea. You have a string, you have scissors here, scissors there, you have the lesion here. You snip here, you snip there, you put it back together with DNA polymerase and ligase. All right. So the things I want you to know on this slide, just to summarize, I want you to understand nucleotide excision repair can happen either during transcription, in which case the damage is detected when the RNA polymerase stalls. Once the damage is recognized, you're going to need to unwind the DNA strands with TF2H. Once it's unwound, you're going to have endonuclease activity that's performed by the xeroderma pigmentosa proteins. And then once that's cut out, DNA polymerase will fill in the gaps and ligase will seal it. All right. Now, global excision repair is only different in one way. The same pathway. The only difference is how it starts. Here, it was when the RNA polymerase stalls. For global excision repair, what you need to know is that XPC is very sensitive to the formation of thymine dimers. So it'll just be minding its own business, floating around. Then it finds a dimer, has a very good affinity to it. It'll bind this lesion, and then it'll recruit DNA binding proteins to form a complex, and then it will directly bind TF2H. So that's where the convergence happens. Over here, you have stalling of RNA polymerase that leads to damage recognition and recruitment of transcription factor 2H and the helicase activity. On the global excision repair pathway, you have XPC, and XPC will bind the TF2H, and it's the same pathway from there on. It's only different in how it starts. So some things about xeroderma pigmentosa that you need to be aware of. It's an autosomal recessive disease that's more common in Japan. A lot of the literature about XP comes from Japan. XPC, some say it has endonuclease activity. I think, in my opinion, not that I expect you to be tested on it, but in my opinion, I think the more important thing you need to know is that it is what sort of recruits everything during global excision repair. All right, and XPA codes a DNA damage binding protein that we'll talk about later. There's an XPV variant that we'll talk about later. The classical presentation is very severe sunburning and photosensitivity with pigment changes by toddler age, which we talked about. Now, from the oncologic perspective, what you need to know is that there is a heightened risk for skin cancer, right? And that kind of makes sense. If you can't repair DNA damage that's induced by the sun, which is usually corrected by nucleotide excision repair. If you don't have intact nucleotide excision repair, if you get DNA damage from the sun, which cells are most likely to be affected first? Skin cells, right? Because that's what's exposed to the sun. Now, there is a higher risk for other cancers, including central nervous system tumors like medulloblastoma, etc. There's also an increased risk for other internal cancers like lung cancer. But the two things you want to know, you have increased rates of basal cell carcinoma, actinic. It's all the whole skin cancer category by, at some point in childhood, and usually by adulthood or middle adulthood, they've developed melanoma. Patients should clearly avoid the sun, and because you're avoiding the sun, you need a vitamin D supplement. So we're going to take a little sidetrack to talk about how vitamin D is formed in very basic levels. You either get it from the diet, right, as provitamin D2, or you get it from the sun, right? Your skin makes it from the sun, and you get provitamin D3. And then that becomes, either way, both become vitamin D3. That goes through the circulation, and in the liver, it's hydroxylated at the 25 position. All right, you get 25 hydroxylation, 25 hydroxylation. All right, and then that 25 hydroxy, the calcidiol, because it has one extra hydroxyl group that was added in the liver. It will then go to the kidney and become calcitriol, because the kidney will do the one hydroxylation. The one hydroxylase activity is very important, and it happens in the kidney. All right, and that's important for calcium absorption, etc., all sorts of processes. Now, the main issue that I kind of want to introduce here is, well, what happens if you have kidney disease? Let's say you have chronic kidney disease. Okay. If you have chronic kidney disease, your calcitriol levels are going to go down. And because your calcitriol levels go down, you're going to have to get your calcium from somewhere else, because calcitriol enhances dietary absorption of calcium. So it pulls the calcium straight out of the bones. And this is called secondary hyperparathyroidism, but we're not going to talk about it. I just kind of want to lightly introduce this topic for you. Take a minute and a half to introduce this topic to you guys. All right. So this requires an interdisciplinary approach, and I think this is a good, xeroderma pigmentosa is a very good example of a medical condition that really requires multiple specialists all working together, along with the primary. You're going to need full skin checks by a dermatologist. There might be surgical management. If you have a complex or invasive tumor or it's somewhere very cosmetically sensitive, you might want a specialized Mohs surgeon or a plastic surgeon. There's ophthalmologic manifestations of xeroderma pigmentosum, and they're common, and you need an ophthalmologist to follow that. And there are some variants of xeroderma pigmentosum where you have neurologic deficits. All right, and a neurologist needs to follow those. One aspect of treatment are retinoids, but we're not really going to go into that today. So here you have basal cell carcinoma. Um, Honestly, I don't know if I could tell you it was basal cell carcinoma just by looking at it. This particular person did have it, confirmed. One of the ways you can confirm basal cell carcinoma is through they have these vessels in them, and that's how you can differentiate it from other um, lesions of the skin. You see these pearly translucent vessels, so it can be, that's the thing about basal cell carcinoma, it can be white and waxy, or it can be very dark. So you really don't know until you check. Um, but I can tell you this patient does have, with xeroderma pigmentosa, does have basal cell carcinoma right here. And you notice it's ulcerating. This is ulcerating. There's some areas of hyperpigmentation. I think you can make an argument that this is actinic keratosis going on up here. So you can see there's lots of pigmented lesions, lots of hyperpigmented um, lesions, some damage to the structures of the eye. The skin is leathery. So you really want to think, what I'm trying to point out here is light induced damage to structures that are exposed to light, the eyes, the skin. And here we have this adorable little baby. So you can see here they were exposed to the sun once, right? And they've got this blister going on. You see, you got some blistering here, and this really erythematous macular rash. Over here, you can see, again, blistering, sun damage, etc. This might be a macule, but I'm not sure. Here you have extensive blistering, but compare the bottom of the feet to the top of the feet. This was spared because of the way the baby was sitting in the baby carriage. This part was the part not exposed to light. So again, it's the light that causes this. Why? Because they don't have intact nucleotide excision repair. And you can see pigmentation is beginning, right? You can see these solar lentigines or sunspots. You can see that they're starting to form. All right. You could tell me that that's a basal cell carcinoma. I would not know right off the bat. I'm just not quite there yet. But could possibly be one. This could be one. This could be one. But what I really want to draw attention to, again, hyperpigmentation. And in African American individuals, like there was a case study of two twins in Uganda. I didn't put it in here, but there was scattered hypopigmentation, right? All right. So now let's come back to nucleotide excision repair. Okay, again, just to summarize before we go into the numbered steps, I'll give you the big picture. You have global genome repair, so this is happening globally, whether it's in transcription or not, and then you have transcription-coupled repair. And transcription-coupled repair, the CS proteins recognize the lesion when RNA polymerase stalls. RNA polymerase is the damage signal. These homies show up and they bring all the other homies, transcription factor 2H, and that whole cascade that involves XPG and XPF, DNA unwinding, making the cuts where the single-stranded breaks end, right? You have this unwinding, you have the not single-stranded break, sorry, the single strands are. So you have this double-stranded region, the part that got unwound, then a double-stranded lesion. And at that junction is where these molecular scissors, the endonucleases, that's where they come in and snip. So XBG, XPF are those endonucleases. And then you get repair through DNA polymerase. Not repair is done through DNA polymerase, but the sense that it fills in what you cut out. And then you have DNA ligase that puts everything together. In some rare situations, the damage still doesn't get repaired. And then there's a post-transcriptional variant of the XP gene called XPV that accounts for a third of all xeroderma pigmentosum cases that is involved in post-transcriptional repair. But we're not going to talk about it in depth. So let's go through the steps one by one. First, the lesion is recognized. Then XPC interacts. So we're talking about the global excision repair pathway, because at this point during transcription, you get the deal. All right. the RNA polymerase stalls, CS shows up, and then the whole same pathway as this happens after that. For nucleotide excision repair in the XP genes in xeroderma pigmentosum, which is why I'm focusing on them here, because that's what's more likely to show up. If I don't think either of these disorders is common or particularly likely to show up on a test, but xeroderma pigmentosum, if I had to put my money, that's the one that shows up, not Cockayne syndrome, which we'll talk about in a second. But I want to give more emphasis to xeroderma pigmentosum, not because it's common, but because there's a lot of, if they decide to test you on nucleotide excision repair, they could ask you straight up, or they could test you through xeroderma pigmentosum. So they can ask you questions about, they say, oh, what is the fault in this disease process? They'll give you the presentation: freckles, early cancers, blistering, and like a 5-month-old who's been exposed to the sun for the first time. He's blistered everywhere, freckles, and you start developing that mental diagram in your head that, oh, this sounds like xeroderma pigmentosum, and then in your options on the USMLE or on an NBME exam or shelf exam or whatever it is, it'll be like, which of the following is the pathophysiology underlying this patient's disease? And they'll have like nucleotide excision repair, base excision repair, mismatch repair, etc. Or they might not say it like that. Instead of saying nucleotide excision repair, they could say endonuclease activity after recognizing a thymidine dimer. Like that's where the defect is in that process. So the level of specificity can vary. It could be straight up, or they could be sneaky and ask you through xeroderma pigmentosum. So let's go through the steps. First, you have to recognize the lesion. Then XPC interacts with the lesion, and that recruits a DNA binding protein complex. Now, transcription factor 2H is recruited by direct interaction with XPC, and H has helicase. H and H has helicase activity, and XPB and XPD are subunits of transcription factor 2H that have the helicase activity. DNA is unwound because that's what helicase does. It breaks down a helix, and the XPA protein is going to verify the damage before you move to the excision repair step. At that point, XPF and XPG are going to be recruited. They're endonucleases. They're going to snip about 30 base pairs around and including the lesion. So remember that diagram? It was double-stranded, single-stranded, double-stranded. Snips on both sides, that the helicase unwound, snips on both sides of it, removes it, and then DNA polymerase comes in, puts new nucleotides, ligase connects them. And if there's a lesion still remaining after that, it's usually excised by XPV, but we're not going to go into detail. All right, and I don't want you to memorize every single xeroderma pigmentosum protein. I think it's unlikely to be tested on it. I think XPC is important because, there's that concept of XPC recognizes the damage. And then transcription factor 2H has the helicase activity, and that encode, and that's, done by XP proteins. And then there's other XP proteins that bring other XP proteins in to SNP. So the idea that I'm trying to illustrate here is that any mutation in xeroderma pigmentosum genes, XPA through XPG, a mutation in any of those disrupts this process. That's the big picture. So do I need you to know that XPG and XPF are going to SNP on both sides? I mean, it's not bad to know, but what I really want you to understand is that each step individually: recognition of a lesion, recruitment of helicase, helicase unwinding, and then snipping on either sides of what was unwound so that you can remove the lesion. That's the big picture. And know that all of that is done by XP genes and XP proteins. That's what you need to know. Now, Cockayne syndrome, kind of similar to xeroderma pigmentosum, you want to think bigger picture. So you're going to have some skin burning, etc., sensitive photosensitivity, but you're going to have also systemic pathology. So neurodegenerative disease, defects of, the spine and the head, etc. There's a bunch of other things. Those are associated with CSA and CSB, which are the transcription-coupled repair. So that's the polymerase stalling. There's no heightened risk for skin cancer or pigmentary changes, and there is an overlap syndrome with xeroderma pigmentosum. I don't expect that to be relevant to step 1. All right, so that's pretty much it. Again, xeroderma pigmentosum, a variety of it's caused by a variety of mutations in XPA through XPG or XPV, and it's a defect in nucleotide excision repair. And because the defect is nucleotide excision repair, and Nucleotide excision repair is most often used to repair thymidine dimers. How do those form? From ultraviolet light. Where does ultraviolet light affect? Skin, eyes. So where are you going to usually have the defects? Skin, eyes. All right, so when you have early presentation with photosensitivity, burning, lesions, hyperpigmentation, etc., xeroderma pigmentosum on STEP should be jumping out to you. All right, good luck.